As Jika said, I am a physiotherapist, so I can't really bear to make you sit for any longer. I don't know how many of you are wearing physical activity monitors? Yeah, how many of them have just buzzed to tell you it's time to move? Yeah, I know mine did, so it's very timely. So please feel free. You don't have, this is not compulsory, but please feel free to stand up, have a stretch, maybe stamp your feet, and just move around, because I've been sitting on your behinds for far too long. So it's entirely voluntary. Thank you, Miloslav, and my colleagues at the back. So I'm delighted to be here today. Thank you very much for inviting me to this beautiful city. We had a fantastic tour guide yesterday on the way home for the directors' meeting, so I've seen a small amount of Brno, and what we've seen so far is lovely, and of course experienced the wonderful Czech hospitality so far. Am I too far away from the microphone? I apologise. So I am a director of a Joanna Briggs Institute Centre of Excellence in Scotland. I'm going to maybe stand here so you can see the slides. Apart from that, I don't have any other conflicts of interest to declare. What I'm going to talk about is, the title of my presentation, as you've seen, is around incorporating qualitative evidence into qualitative research into evidence-based guidelines. And this is in the this is under the auspices of the SIGN methodology, SIGN, which is the Scottish Intercollegiate Guidelines Network. And I'm going to talk a little bit about just our experience of a project that we're doing at the moment, a collaboration between the Scottish JBI Centre and SIGN around a particular guideline, which is on childhood epilepsies. I'll talk a little bit about the methods that we've used to incorporate what I've called non-traditional evidence, because actually it started out as we were asked to come in and advise around incorporating qualitative evidence into the guidelines, but actually what we found was it wasn't just qualitative evidence that SIGN didn't have methodology for, it was other types of evidence as well. And then identify some of the limitations that we've encountered, and then that's leading to some suggestions for future work. I'm just going to... Apologies, I'm most likely going to lose my voice as well. So, as I said, I'm from the Scottish Joanna Briggs Institute Centre. So, as all good presentations have to have a photo and tell you where we're from, Scotland is that little dot. Well, Scotland isn't the little dot. Scotland's the green map, but Aberdeen's the little dot on the northeast corner of Scotland. Some of you have been to our centre last year for this symposium. And that picture at the bottom is what we think is our rather lovely university campus. And SIGN's the Scottish Intercollegiate Guidelines Network. And as I said, this is very much a collaborative project between myself, a centre director, my colleague Pamela, who can't be here this week, but she is from the School of Nursing, and also my centre deputy director, and then colleagues from SIGN. So I'm really presenting on behalf of everyone here. Sarah Florida James, who's a programme manager in SIGN. And then this subgroup of our guideline, the guideline development group, which was quite a large group, and then the subgroup that was looking at the two key questions that we were incorporating the qualitative evidence into. And you can see that we had a multidisciplinary group. So just a little bit about SIGN. SIGN is it's part of a special health board in Scotland. So Scotland has health boards for each regional area in Scotland, and then we have some special health boards that are responsible for the provision of healthcare and organisation of healthcare throughout Scotland. So Healthcare Improvement Scotland is obviously about improving healthcare throughout Scotland, and SIGN sits within that. And SIGN had its 25th anniversary. 93 was obviously a very good year. It was also the year that I got married and SIGN was produced, so that was a good year. So SIGN's been producing evidence-based guidelines in Scotland for 25 years. And where guidelines are required. So, as was said earlier, SIGN will adopt guidelines from elsewhere, or they'll create new ones where they're required in Scotland. So why qualitative research? And this is not new, and there's probably people in the audience who have been doing this and have been utilising qualitative research and evidence-based guidelines. So if I'm preaching to the converted, I apologise, but I thought it might be useful to share some of our observations around how we've gone about this. And there's been quite a lot written very recently around qualitative research and guideline development. And in fact, this year, you can see that quote there from Lewin and Glenton, who said that we're entering a new era for qualitative research. So as a qualitative researcher, it's really nice that, you know, and I'm sure there are many of you in the audience who are qualitative researchers, that qualitative research, the worth of it, the fact that it can be utilised in evidence-based guidelines is really a positive thing. And there's quite a number of organisations have incorporated and are increasingly incorporating qualitative evidence into their guidelines. So organisations like NICE in the UK, NICE worked with the Social Care Institute for Excellence in the UK a number of years ago around a couple of sort of pilot projects for them utilising qualitative evidence. The World Health Organization has written about this, examples from South Africa, Sweden, and you know, many, many places. So, of course, the benefits of utilising and incorporating qualitative research evidence are that we're not always only interested in effectiveness of interventions when we're looking at guidelines. We're also interested in things like acceptability, feasibility of interventions, increasingly the perspectives of service users and carers, and if a guideline can say something about that as well as something about the effectiveness, and if it can also say something about the process of delivering healthcare and some of the implementation issues as well, then obviously that's much more helpful to a clinician who's trying to utilise and implement the recommendations from a guideline. And the reason that qualitative research is increasingly being used in guidelines, of course, is that in recent years particularly, methods have greatly enhanced reporting standards, have enhanced the quality of what's published in journals. We know that we have much better methodology for synthesising qualitative evidence. There's a number of people here who are Joanna Briggs Institute reviewers who frequently conduct qualitative or mixed method systematic reviews. It's also easier to find, so indexing is much better. We can find qualitative studies, we can find qualitative systematic reviews. And obviously the development of methods for looking at the confidence in findings and things like evidence to decision frameworks that were talked about earlier are all enhancing not just qualitative research, but obviously enhancing lots of different types of research. So I'm going to give just a brief overview of SIGN methodology for those who are not familiar with it. And the way that SIGN works is topics are recommended usually by individuals or groups of people. So commonly what will happen is a clinician or a sort of interested, a working party or an interested sort of group of people will identify that there's not a guideline on a particular topic and that they think there should be or they would like one. And SIGN will go through a process including looking if one already exists that they can adopt or adapt from elsewhere. Goes through a process in various committees for them to decide whether they're going to invest the resources in developing one for the Scottish context. And that's all informed by wide stakeholder consultation. They then conduct a systematic literature review for each of the questions that within that topic. And as has been said before, just like all, I think, guideline development methodologies, produce evidence tables, assess the methodological quality of that evidence, and then they do use a considered judgment process. So that guideline development group, and I'll show you what that looks like a wee bit later, of really experts in the field, of patients, carers, service users, different stakeholders, will look at the quality of the evidence on that particular topic and think about the factors that can affect the strength of recommendation. And a lot of this has been mentioned before already. So, of course, we're looking at risk of bias, heterogeneity of findings, whether the findings are actually directly applicable to the population of interest in the clinical condition in the Scottish context, are they precise, and are there any other sort of biases that need to be taken into consideration. And then that guideline development group will make a recommendation. So they'll take all the research evidence, clinical expertise, and patients' values into consideration, and will arrive at consensus and make recommendations that are either strong, if there's enough research evidence to back them up, or they may be conditional if the research evidence is perhaps not as strong or as high quality. And they may or may not come along with good practice points as well, which are generally expert opinion, which has been talked about earlier. And I was very interested to hear that because we're at the stage of getting a lot of expert opinion back on our draft guideline, which is very interesting to have a look at. So the next phases of sign methodology are and the stage that we're at the moment with the guideline we're involved in is that it's out for consultation. We had an open consultation meeting in Scotland last week, where quite a large number of people came along. The guideline was presented. It's been sent out for peer review to invited peer reviewers, and it's been on the Signs website for a few months so that people can just look at it and provide their own thoughts and peer review comments. It'll then obviously be published and implemented. So that's the kind of process, and I thought that just important for you to know what it goes through. So the guideline that we're working on with the qualitative research is epilepsies in children and young people, investigative procedures and management. And I suppose I do have a declaration, not an expert in epilepsy. So please don't ask me questions that are specific to the clinical aspects of this guideline. We were working with our methodological expertise from being JBI systematic reviewers, particularly with qualitative experience, along with a number of people who are experts in epilepsy. So our guideline development group, you can see it had all the people that I think it should have had, a range of clinicians you'd expect to be involved in epilepsy, some science staff, the programme manager who was leading and facilitating the development of the guideline. We had access to health economists, information scientists, and then really importantly, obviously for all guidelines, for this one in particular, that we had lay and voluntary body representatives. So young people with epilepsy, their parents, carers, including parents of people who'd lost young people to epilepsy, and various different networks and special interest groups. So basically, I'll go over this very briefly because I've told you what the process was. A need was identified. There were 11 key questions identified that needed to be looked at. And when the literature review was conducted, what the information scientists found and reported back to the group was basically that they'd found what I've termed non-traditional evidence. So sign methodology traditionally would look at all the quantitative types of evidence and it doesn't actually have a methodology for incorporating qualitative and other types of evidence. And that's where, because we've been having, we're involved with SIGN anyway around discussions about how to broaden the evidence that they use, we thought this would be a good pilot project. So the two questions that returned this evidence were around the transition process. So at consultation stage, they wanted to find out at what age and by what process. And basically, it turned into a quantitative PICO was developed because that's what SIGN were used to doing. That asked the question around, it was something like, is a structured transition process more effective than an unstructured transition process in children with epilepsy? And of course, there's not literature really that answers that question directly. And there also wasn't literature that answered directly the question of exactly when children and young people and parents and carers should be told about the possibility of sudden death in epilepsy, which is SUDEP. So essentially, they couldn't answer the key questions in the way that they'd been presented. So we did a little bit of kind of going back and not restarting the process, but doing some more stakeholder consultation. And actually, when we did that, it turned out that actually the question that they wanted to ask about transition was, what are people's experiences of it? What does the literature tell us, the evidence tell us that people's experiences of it have been to inform what we should recommend around how transition should happen? So a further systematic review was conducted, and we found some literature. We found an existing systematic review, but not in epilepsy, just on neurology in general, but that was still utilised to inform the guideline. But we also found other types of literature, so some more recent types of literature like scoping reviews, mixed methods reviews, and then we also found a number of cross-sectional studies which SIGN methodology didn't usually incorporate, and text and opinion as well. So what we actually did with this was we used our JBI methodology, and we used JBI critical appraisal tools where possible, because we don't have a critical appraisal tool for all of these evidence types. And by doing that, and then giving all that in the evidence tables to the guideline development group and working with them, we were able to make a conditional recommendation So not a strong recommendation, but still a recommendation. And there were also 2 good practice points that came out of that. And in terms of the sudden death in epilepsy, what we found was actually, yes, when should people be told about sudden death is important, but there's legislation around that and there's lots been written about that. So actually what people were interested in was, it's more where should this take place, how should it take place, who should be involved in this discussion as well. And when we went back and did more stakeholder consultation, that's when we decided that actually we needed to do a new systematic review looking at when, where, how, and who should be in there, discussions should take place. And due to the literature that we found, and the fact we were then looking more broadly, not just for quantitative studies, which the information scientists originally looked for, we have been able to conduct a new mixed methods evidence synthesis that's still ongoing, and we're just coming to the end of that now, incorporating a range of literature. And we also found some other studies that didn't quite fit into that new, the PICO for that mixed methods synthesis. So we've also incorporated into the guideline some additional qualitative studies and mixed methods primary studies as well. And with these, as we did with the transition question, we've critically appraised them using the JBI tools. And we used JBI Conqual to look at dependability of the individual studies and then credibility of the synthesized findings. Now, there's going to be a presentation just after this looking at Conqual and grade Serqual, so I'm not going to say too much about Conqual. Thank you. And for the SUDEP one, we were able to make a conditional recommendation, but because we have the results of the mixed methods review pending, it's likely that we will be able to make more recommendations as well. So essentially, by incorporating the qualitative evidence, they were able to go from not being able to address 2 of the key questions in the guideline to being able to at least provide some conditional recommendations with really quite important and very patient-centred information around how transition should happen and around how that difficult conversation about the risk or the potential for sudden death in epilepsy in children as well. The main limitations we found were that because the guideline development group is largely made up of clinicians, they were much less familiar with the types of literature that we were incorporating for these 2 key questions. So we spent a lot of time on basically training and upskilling around methodologies and how to read basically some of these literature types. Also, because this process really evolved over time, and we had to go back and do further stakeholder work, it has been quite a lengthy process. And we're discussing with SIGN at the moment how we can, or how they can plan really for trying to identify that perhaps qualitative evidence or other types of evidence are likely to be included in a guideline, and how to start it from the beginning so that we don't have to go and repeat some of the processes. We did find a lack of critical appraisal tools for some types of evidence, and of course we won't know until the guideline is published and then the implementation process as to how clinicians find the interpretability and the implementation of the recommendations for these 2 questions. And that leads me on to future work. I think there's work to be done around critical appraisal tools for some evidence types. There's definitely discussion to be had around grade Serqual and the use of grade in general. SIGN are certainly signed up, for want of a better word, to the principles of grade, but not currently going through and incorporating the whole process. And that's certainly a discussion that we've started with SIGN, and I might be interested to discuss that with you later on. And it's all very timely because SIGN 50, which is the Guideline Developers Handbook that I noticed you referred to previously, Miloslav, as well, is being reviewed at the moment. So the findings of this pilot project will be incorporated into SIGN 50, and we certainly hope that it'll become more just routine practice that qualitative and all other types of evidence are considered for inclusion in guidelines. I have a few references if you're interested, and thank you very much for listening.
Thank you. It doesn't work?
And sorry, I think I took a long time.
No, it's totally okay. Maybe I can scream a little, and then you can, but it works already. It was really very, very interesting because sometimes we are so much focusing on the technical parts of treatment and diagnostic, and the soft skills, so-called soft skills, are somewhere behind us. So thank you very much. I don't want to restrict the discussion, but we have limited time for that, as we would like to keep the time. So we have just time for one question. Do we have one question from auditorium? Professor Schoenemann and Jalodi. Okay, man, if we have so important person here, we could have just two short questions and short answers.
Very short. So could you just elaborate very quickly on the distinction of using qualitative evidence and quantitative evidence for the criteria such as feasibility, acceptability, and equity, for instance? So what are your thoughts on that?
I'm not sure I entirely understand the question.
Okay, I try to be very quick. There are two types of evidence, if you want to call it this way, qualitative and quantitative. They both can be used for feasibility and acceptability, for making judgments about feasibility and acceptability of an intervention.
Yes.
When to use which?
I'm not sure I have a short or very easy answer to that, but I think really what we were looking at was currently under science methodology and their handbook and how they operate, they would only look for and utilize quantitative evidence. So that old, like the evidence hierarchy, that pyramid that you showed, I think, earlier on. And I think that yes, there are quant studies designs that can. I don't particularly like the quant-qual distinction because I see research as a continuum anyway, and everything's relevant. But I think really what we are saying is that it's important to include everything that's looking at feasibility and acceptability and appropriateness and patient preferences, and that the qualitative evidence is just as important. It might be rated differently or graded differently, but I think it's important to incorporate it all rather than say, well, we'll look for this type of evidence or this type of evidence. I think what we're saying is we need to look at it all.
Professor Jalodi?
Very short question, ma'am. Is there any relation or connection between your activities and the national health system activities with NICE and with all the story which is traditional in Britain?
So NICE is, if I'll give you a history or a history of the UK, I guess. NICE is an English system. So in the UK, although we're a very small country, and we are four, as people know, we are Scotland, England, Ireland, Northern Ireland and Wales.
I can understand easily, we are Moravians, we are not Czechs here, yeah?
Absolutely. So, and it's really, we are the UK, and I am British and all the rest of it, but in Scotland, we have a completely different healthcare system to in England. And although the perception is, and at the risk of offending my English colleagues, the perception is that what happens in England goes north and happens in Scotland as well. It's not actually the case. We have two very separate systems. So we have ended up that we have, because healthcare is a devolved power, so the Scottish government controls healthcare in Scotland, the English or the British, in fact, government in England. So NICE is the guideline development organisation for England, although it's probably internationally known as, the UK, and SIGN is for Scotland. But they try not to duplicate each other and work very closely. So if a NICE guideline exists on something, SIGN will usually not typically go out and produce their own just to do a Scottish version. They'll adopt a NICE guideline. But where a topic suggested that maybe a NICE guideline doesn't exist, that's when they would create their own.
Thank you very much.